Hello, welcome to JAMA Network Open Live. I'm Seth Kruger, digital media editor at JAMA Network Open. Of course, if you're following along live, please join us on Twitter at JAMA Network Open, where you can send your questions or comments, or send us your questions and comments on Facebook or YouTube Live in the comment box. Today, we are talking about the laboratory findings associated with severe illness or mortality among hospitalized individuals with COVID-19 Eastern Massachusetts. And we've got senior author and JAMA Network Open associate editor, Dr. Roy Perlis, with us. Welcome, Dr. Perlis.
Thanks very much, Seth.
So, of course, you were with us back, was it in April or May? We did a little COVID talk on social media and preprints in the time of COVID. But for those who don't remember, tell our watchers who you are, what you do, why you did the study here.
Sure. So I'm Roy Perlis. I run the Center for Quantitative Health here at Mass General, and I'm a professor of psychiatry at Harvard Medical School. And I think a subtitle for this paper might be, "What else did I do while I was locked in my attic this spring?"
Yeah, see, your analysis was in June, July 2020, which is a time where I think a lot of us were figuring out stuff to do outside of work.
Yep,
Yeah. So tell us what you did in the paper here.
absolutely. So, kidding aside, in the spring, my wet lab was shut tight. Our clinics were all remote and was sort of waiting to be redeployed. And the other area where I work is in electronic health records. So we started thinking about what can we do that would be useful. Um, and the thought was, could we develop a simple model to predict risk for adverse outcomes using things that didn't require any additional effort? Because the folks on the front lines are already so stretched. Asking them to collect any additional information, do any additional sort of non-critical work is sort of unfair. On the other hand, we're sitting on top of this feed of lab values, this sort of constant stream of data. Could we do something simple to help us make predictions about who was going to do well and who wasn't going to do well?
Yeah. I'll do the brief summary. You have six hospitals in Eastern Massachusetts. You have 2,500 hospitalized patients, about 1,900 in the training set, and then 600 in the test set. Mean age was 63, which is on, I think, the younger side for pretty sick patients. They're pretty sick, 9% in the ICU, 7% intubated, and 12% died. And basically, you did I'd say, an advanced regression. I was expecting machine learning, but just regression. And then so tell us what a little more nuts and bolts about what that means.
Sure. So, I think it would have been pretty simple for us to do the hocus pocus, we train naive Bayes or deep learning or whatever. The reality is, in a lot of applications, regression works pretty damn well. And the advantage of regression is it's pretty transparent. It's easy to explain what we see. Um, and the thought was, if we're going to ask docs to potentially make decisions on the basis of this tool, we really have to be pretty clear about why, what's driving the predictions. So that was part of what motivated regression. The problem is standard regression, you have the dimensionality problem. You basically have too many variables. And another way we could have gone is this sort of careful crafting of, well, I think this variable is going to be important. I think this variable is going to be important. If we were approaching it now when we know so much more about COVID, we might have done that. But at the time, it was more, I don't know which one of these variables is going to be most predictive. We have a lot of labs that we're getting on pretty much everyone who gets admitted. Let's let the algorithm teach us what's going to be most predictive. So we used, as you mentioned, we used kind of penalized regression called lasso that more or less sort of shrinks the coefficients of all but the most important predictors. And so you end up with a model that instead of 20 or 30 or 50 predictors, you have 5 or 10, which is a more tractable approach.
Yep.
And,
So
just the thing I would say is we have looked, it's not in this paper, but we have looked subsequently at other kinds of machine learning models, and they're fancy, they're sexy, they have lots of bells and whistles, and they don't do very much better than this model.
yeah, interesting. Yeah, and I saw the basic things. Your AUCs are zero point 0.8 for severe outcome and about 0.85 for mortality, which are generally pretty good. And looking at figure two, if you put people in quintiles, there's pretty impressive stepwise increase with both severe illness and mortality, which I think overall shows at least face validity.
And I think that's the key. We weren't necessarily after something that was going to be perfectly predictive, because that, for a lot of sort of messy real world problems, is just not realistic. All we wanted was something that would let sort of hospital decision makers, folks in the ED, folks on the medical floors, say this person's higher risk, this person's lower risk. And you're absolutely right. Those essentially calibration curves, that figure, it tells me that high risk is at greater risk than low risk, and that's kind of what we were after.
Yeah. So what do you see this being used for? Is this kind of thing that should be like plugged into an EHR by itself and just it pops up and says this patient's at X% risk or considered the ICU? Or is this kind of the more for like a hospital planning dashboard than a clinician?
So I would say, first of all, that fortunately, compared to the spring, mortality rates, I think across the country and internationally, are way down because we've gotten better at understanding how to manage the disease. So I think any hospital that wants to implement this kind of calculator probably would have to do some recalibration. But frankly, we put this out there as quickly as we could because we hoped that people would use it. Because even if I can't use this calculator at this point and say your risk is 30%, it's still a useful way to say this person's high, this person's low. So, at my institution, it would take approximately a decade to get a calculator like this implemented in our electronic health record, which unfortunately is epic. But for people who work at hospital systems that have electronic health records that are more flexible, more open, absolutely, we want people to use this. That's the whole reason the coefficients are listed in the paper.
And again, sorry to pin you down a little bit on this, not to be mean. When you say people to use it, do you mean like an on the ground physician like me trying to say like you should go to an ICU, you should not go to an ICU, or more for like the 10,000 foot people saying like, wow, we need 8 more ICU beds. There's a lot of people with high scores.
So, obviously this isn't a substitute for any kind of clinical judgment.
Yeah,
And,
sure,
and,
sure.
and also part of why we put this out there was to, in a sense, challenge other people to say, do better, right? So probably pay more attention to vitals. You could do even better, incorporate other labs or other physical exam findings or imaging. So we wanted to sort of set the bar as like, here's a starting point. But yeah, really my hope was that folks sort of close to the initial admission, so whether you're still in the ED and labs are coming back, or a patient's been admitted to a medical floor and labs are coming back, would, in combination with other clinical data, say, gee, this person's in the highest risk group. We maybe need to have a low threshold to transfer them.
Interesting. So I'll tell you the kind of my clinical experience with a lot of these patients as an ED doc is, there's the overall gestalt, how the patient looks from the door, how they're breathing, how like the arc of their trajectory, like, oh, they were breathing like crap before, we'll put them on oxygen, they're doing a bit better now. Their stats overall, their stats with support, do they need, oxygen or respiratory support? And then of course, blood pressure, no one's going to the floor with a 60/30 map or blood pressure. But the other labs seem kind of informative and help us like figure things out. Like, wow, that guy with the D dimer of 2,500 is probably sicker than the same guy with the D dimer 200. But that's not making us think like, oh, this guy's the one who's going to crump. Is there? Do you think we'll be at a point maybe where, as something like this evolves, it helps us do that kind of prediction? Because we've certainly seen people where I've seen people come in pairs who look identical, and one is intubated 6 hours, one's intubated in 6 days.
So first, I want to just point out for the audience that I think Seth is talking a little slower than usual, and he's translating a little bit more because he knows I'm a psychiatrist. So I appreciate that. No, I think you put your finger on potentially one of the best use cases here, which is this person looks pretty okay, but their score is really high. Maybe I need to pay a little bit more attention, right? I don't think it should drive decision making, but I think it's another kind of, it's like you're in the cockpit of a plane and you've got all kinds of lights flashing and gauges and whatever. It's helpful to be able to boil that down to kind of how worried should I be. So I'd like to see this, if people apply this or things that follow from this more as like another voice saying, hey, wait, maybe you need to pay a little more attention.
That's a good point. And the more I think about it, there are certainly a lot of edge cases where we're like, I don't know, maybe they need the ICU or they're doing okay on 6 liters, but do they need to go up to high flow or think about intubating them or something like that? So I think having another big data point might be helpful at that point.
Yeah. Again, it's just another way of aggregating over a whole bunch of complicated data to try to boil it down.
Yeah, and looking through too, I noticed LDH is on here, but with a pretty small coefficient, and that's something we certainly, I think, we talk about and we see is higher in the sicker patients. I noticed D-dimer didn't shake out into your model. Can you talk about that at all?
Yeah, so when you build a model like this, you're basically asking to pick the coefficients or the pick coefficients for the predictors that have the largest effects. And so if the model finds other coefficients that or other predictors, other variables that capture more of the variance, those are going to sort of play a bigger role in the model. So essentially, it may just be, it doesn't mean D-dimer is not important in isolation. It just means another combination of predictors. Um, Particular blood counts, for example, were more useful in prediction. That's all.
Okay. Well, very interesting. Well, fortunately, at my shop, we do have the ability to get some calculators in our system, so I'm going to forward this to our ops team just to see if they want to play with it at all. Maybe do some research on it. But that's your. If there's nothing else, that's what will win.
So, I appreciate that. So the other thing to know about the paper that I think makes it worth paying some attention to, even though, obviously there's been a lot of other stuff published about labs and so on. We were very careful at the beginning to say we have a big health system with multiple academic medical centers and multiple community hospitals. And we're just going to chop it right down the middle. The hospitals are all different. And because we did that and really looked at our model an independent set that was both academic and community hospitals, it really should generalize better than if we just split a single academic medical center into two pieces or something. So again, like the goal was really something that would be useful and that would inspire other people to further develop it.
Yeah, and there's so much variability, I think, between just the kind of practice of who goes to ICUs or what different floors can do. Like a number of years ago when I started my current job, it took me a while to realize why we had such a low threshold to do DIL drips and AFib, and then I realized they could go to the floor. They didn't have to get rate control to go to an ICU. So it was there's so much little stuff like that. So I think that kind of heterogeneity and insight is really helpful for external validity. Just throwing some fancy stats words.
Well, no, I mean, we tried to set the bar. I mean, and the thing is, if we had done it just in a single hospital, if we'd only taken Mass General,
Yep.
we would do much higher AUCs and PPVs and NPVs, but
Right.
not the real world.
Right. I mean, it's as I'm trying to understand all these complex concepts throughout my career, that sounds closer and closer to overfitting,
Yeah.
basically.
Yeah.
So I do want to show you have some beautiful Kaplan-Meier curves. So figure 3A shows you really differentiate the severe outcomes, which is interesting because you get pretty good separation from the quintiles. I guess you're really going from, is it 30 something percent to 90 something percent? That's a pretty big difference in outcomes.
Yeah. So the story behind the KM curves was right as in the midst of working on this. So this paper went through a few different iterations as we got more data and so on. And you may recall there was a pretty prominent paper that didn't account for the fact that people leave the hospital, and so it actually didn't. It didn't adequately address the fact that data are censored after a certain point. So the whole idea of the survival curve was to show, even though we didn't build the model specifically to look at survival as a time variable, it actually does pretty well in distinguishing. So yeah, it's another illustration of it's not a perfect, it's not a perfect classifier, but that high risk group is pretty high risk and probably does need additional attention.
Yeah, and if you switch to figure 3B, the mortality Kaplan-Meier curve, you see basically all four quintiles do pretty well except for that fifth quintile, which, basically everyone's mortality is over, or survival is over, I think it looks like 95%, and then the fifth quintile is around 60%. That's a huge gap there. So
we were happy with the calibration, and one thing that I should mention is we did go through carefully and make sure it wasn't driven by any single predictor. There was no obvious confounder. It wasn't, only a particular subgroup of patients. So we did a lot. There's a lot of tire kicking over the sort of May, June, July period to make sure that this would be solid.
Right, and that's great. And I would say on the one hand, well, I think it would be nice to have a nice, I don't know, like fan of different levels across. But like this, I think resonates with what we see on the ground is that some patients do really badly, most patients do okay, and there is a pretty big differentiation there.
You also have to keep in mind, I mean, we basically took the first value we got. So I don't doubt, we're trying to make a prediction as close to when someone hits the door as we can.
Okay.
And I definitely, one of the extensions of this model that I think would be useful is to go back and say, okay, now do the same thing on day 3. Now do the same thing on day 7 and see if your predictions can get better.
That's good. Well, even if it's just things like not even lab values, but stuff just like vital signs, ventilator support, that kind of stuff might be interesting. So we'll see you in a few months with that follow-up paper.
Exactly.
Great. All right. Well, thank you so much for joining us today. We went a little over our time, but this is a fascinating topic. Before I make a joke about getting into exit polls, I'll thank you and say goodbye. So, of course, if you're following, you can get this paper free and open access on JAMA-networkopen.com. Join us next week, November 10th at 3 p.m. Central Time for the next episode of JNO Live. And, of course, stay safe, take care, and if you haven't yet, vote. Take care.
Thanks.